Let's talk about multiple sclerosis. So to start off here, we can discuss a brief overview of MS, which I know that you've had in your clin med course as well. But briefly, multiple sclerosis is a disease that's represented by multiple areas of scarring or plaques throughout the central nervous system. It is isolated to the central nervous system, not the peripheral nervous system. It was first identified by a famous French neurologist, Jean-Martin Charcot. And that's just an interesting fun fact because Charcot also discovered numerous other neurological deficits that are actually similar to MS, like Charcot-Marie-Tooth disease. So, MS itself is an autoimmune disease characterized by a course of inflammatory attacks leading to demyelinization and slowing down and eventually halting of saltatory conduction in the CNS. That's a textbook term. It's an important term to know and remember. But let's talk a little bit more about the real world implications. So we know that our nerve bundle is surrounded by myelin in the central nervous system, that is, and multiple sclerosis impacts the myelin significantly. So what happens is we have a destruction of the myelin. We have scarring, which is called astrogliosis, and that's actually scarring down of the glial tissues. Then we have destruction of the oligodendrocytes, ultimately leading to irreversible axonal damage. So when you look at this picture here, it really represents the top here, a normal nerve with a normal amount of myelin surrounding it, the nucleus safely underneath, and then deep down the axon safe. When you come down here to a damaged nerve due to multiple sclerosis, we see the myelin's been damaged, and now multiple areas of the nerve are open and exposed. What this image does not show is the scarring, which then replaces these blank areas where the yellow is no longer here, the myelin's not here. The scarring down is one of the major challenges, and that's what actually negatively impacts the nerve conduction at that point. So let's move on here and to talk specifically about symptoms of multiple sclerosis. Honestly, we could talk all day about this. When you come back to your basic neurological discussion, your basic understanding of the neurological system, any area of the central nervous system can be impacted by multiple sclerosis. The brain, the spinal cord, the brainstem, ultimately resulting in damage to cranial nerves as well. So the symptoms of multiple sclerosis can be anything that is impacted by the central nervous system, which is ultimately every function we have. So there's a lot of summaries around, and there's a lot of details about what are the more common symptoms, and we'll even talk about them today. But in general, come back to your good old understanding of the central nervous system, being able to define the regions of the central nervous system, and the impact that an injury to any region would have, whether it be a brain injury, a stroke, or now a plaque or demyelinization from MS. So the etiology, there's a lot of research being done to really try to understand and determine the cause of MS. But one thing we can discuss is the etiology, in essence, the interaction between the genetic predisposition, an environment, some sort of antigen within the environment, and the susceptibility of the host. So genetics actually do account for a fair portion of MS. The risk is 1 in 750 for getting MS in general population, but it's actually 1 in 40 for someone with a family history of MS. So that shows to us a genetic tie in some capacity. That said, siblings are only at a 3% risk, fraternal co-twins 5%, and identical twins 25%. So while there is a genetic component to it, there obviously must be some external factors that contribute. Otherwise, identical twins would have a much more than a 25% rate. So exposure to viral agents, that could be that external stimuli, anything that impacts the immune system, anything that's going to impact your central nervous system as a whole. Sorry, let me turn off my notifications. So Epstein-Barr has very strong correlation with MS, but there is no definitive concern here. It's just that a majority of people that have MS actually do present with traces of Epstein-Barr within their system. There's also a relevance to measles, canine distemper, human herpes virus, and chlamydia. However, none of this has been scientifically proven. These are all causations, if you will. And it's important that you understand the difference between this. It is not directly caused by any of these. People that have MS will often report having had many of these 5 different diseases or viruses, but there's no direct correlation. So prognostic indicators, you have favorable prognostic indicators. Females do perform better with MS. An onset at a younger age, so before 35, is definitely a better prognostic indicator. Monoregional versus polyregional attacks being throughout the body. If a person has initial symptoms in one area versus multiple areas, they will have a better outcome. And complete recovery after the first or second attack. Unfavorable prognosis. Males have a less positive outcome here. Brainstem symptoms, anything related to ataxia, nystagmus, tremor, or dysarthria. Poor recovery after exacerbations, and high frequency of attacks. So the epidemiology here, there are actually geographically high-risk areas, and this is important to understand. There is an increased prevalence in areas farther away from the equator. So the closer to the equator, the less risk. Some areas where we've seen significant outbreaks, if you will, of MS, the northern US, northern Europe, southern Canada, New Zealand, and southern Australia. Low risk would be Africa and Asia. So this is a nice map of a global distribution of high risk versus low risk regions. It's really just a visual representation of the risk areas. So there were studies done to determine if it was an area where a person grew up or if it had to do with an area where a person lived. In other words, was it something that through their time living there in childhood had an impact on them, causing them to have a higher likelihood of MS, versus having an antigen in the air in that local area that caused or triggered MS. So what they came up with through multiple studies is essentially where a person spends their first 15 years of life determines the likelihood of developing MS. So it's not necessarily an antigen that's in the air that will trigger MS at the moment. It is actually something in that region that will cause the potential to have MS later in life. But it's during that first 15 years that the impact happens. So moving away from the equator at 20 years old will not increase your risk for getting MS. However, if a person were to be raised in the north, far from the equator, until they're 15 and then move close to the equator, they're actually going to have a higher risk of developing multiple sclerosis. So essentially, if you're born north and you move to the south at 17, you're at a higher risk. If you're born in the south and you move to the north at 17, you have a lower risk. And you can kind of work through this if you have any questions about this. Females more than males, this is a 2-to-1 ratio, pretty significant. It is more prominent in Caucasians, less so in Africans and Asians. It is uncommon before adolescence, although in recent history, while we don't have the census numbers, we've been seeing a lot more studies about teenage diagnosis of multiple sclerosis. That said, we can still safely say that 20 to 40 years old is the most common age of onset. Greater than 60 years old, it's uncommon to be initially diagnosed. Although I will say, in my experience, I've seen a handful of people who were diagnosed after the age of 60. The survival rate, this is a game changer in the world of rehab medicine. So in 1980 to 89, the survival rate was from 15 to 40 years, which really represented a significantly shortened lifespan. So if the average age of diagnosis was between 20 and 40, that means the average age of death was between 35 and 55 on the low end of that survival rate spectrum. Now, that said, things have changed significantly. The treatment for MS, the diagnosis of MS, and the exercise prescription recommendations for people with MS. So as a result, we can currently say that people who are diagnosed with MS will live to have an almost normal lifespan. Almost a normal lifespan. That's significant. So the relevant anatomy, this is something that has been discussed previously in other coursework, and you could certainly take a closer look at these pictures to help you understand the saltatory conduction and demyelination. You take a closer look at these pictures to see what the plaques might look like in the spinal cord or the brain. But overall, what we care about, and actually looking at this one here, is a great way to look at this. What we care about is these hyperresonant areas. These are actually considered plaques. These are active areas of cell death. In MS, the brighter on this type of scan, the brighter it is, the more active it is. So we can see a number of active lesions, and then perhaps an older lesion over here. And then a hyperactive, and then maybe older over here. If you can't see my mouse clicks, I apologize, but you can look through the picture here and see the hyper versus hyporesonance. But ultimately, what this means to us is that we're working with a disease that has focal deficits and focal lesions on the brain and spinal cord. So at the end of the day, when it comes to symptoms, we come right back to our original discussions on what region of the brain is impaired, and that will ultimately tell us what our symptoms are going to be. Now that said, there are some other symptoms that are unique to MS that we'll talk about later. So it's not 100% focal. There are some generalized symptoms like fatigue and sensitivity to heat and lassitude that we should talk about. So the pathophysiology is really the most important thing to understand when it comes to MS, because this gives you a sense of exactly what's happening in the person's body, and that now explains to you how we can diagnose it so easily now versus many years ago. So we already talked about what happens, but in essence, there's a disruption in the blood-brain barrier. Something happens, a reactive astrogliosis. As a result, we have production of the brain antigen called a glial fibrillary acid protein, so GFAP or GFAP. That causes further disruption and actually mobilizes lymphocytes and macrophages to the scene. So this is our immune response. Now remember, MS is an autoimmune disease. Autoimmune is when your immune system attacks itself. So for some reason that we don't know, we end up with a reactive astrogliosis, which is where we ultimately activate our lymphocytes and macrophages to attack ourselves. So those macrophages initiate destruction of the myelin sheath and the cell bodies of the oligodendrocytes. And remember, the oligodendrocytes are the regions of the central nervous system that produce more myelin. So not only is the myelin being taken out, but the factory that produces myelin is being taken out as well. Then we have fibrous astrocytes filling the demyelinated areas and forming the glial scarrings or plaque. At the end, we have cytotoxic lymphocytes and macrophages present in the plaques, which lead to edema. They can also have a mass effect and actually present themselves like a tumor. And these are going to be our plaques and our lesions. So we can see how we've had a breakdown of the myelin, which is negatively going to impact the nerve conduction. Then we further had scarring, which is going to negatively impact the nerve conduction. So the successful treatment of MS exacerbations is with steroids, and that's in part because the drug's ability to control the edema resulting from the inflammatory process. So when you think about that, when somebody has an exacerbation, it's not that the medication in some cases is directly treating the exacerbation. All it's really doing is reducing inflammation and letting the exacerbation take its course. Now, we're fortunate that not all oligodendrocytes are damaged during this exacerbation, so we have the potential for remyelination. The problem here is that waste that was left behind, the scarring. We could have, if we are left with oligodendrocytes after an exacerbation, we could have a full, complete recovery if there were no demyelinated regions with scarring. Once you have the scarring and the plaques, it becomes impossible for the oligodendrocytes to lay down new myelin, and as a result, you have a permanent change in your nerve conductivity. This is super important because this, in my opinion, represents the future treatment and ideally the future cure of multiple sclerosis. If science can continue in the direction they're going, they should be able to figure out exactly how to clear out those waste areas and how to clear out those plaques. And once they do, they can then empower the surviving oligodendrocytes to produce more myelin, and we'll have a much better handle on MS, and ultimately, most likely, even a cure. There's a number of studies going on in many, many different areas, but this is one of the main areas where the research looks promising, and I think there's great potential for success. Now, the specific types of MS. This is an area where we can discuss all 4 different types of MS. Now, there is a 5th type of MS that is actually questionable, and right now it's not being discussed in the board's materials. It's not being discussed as a viable type of MS. So for now, we're going to just discuss these 4 primary types. We have relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. So relapsing remitting is the most common by far. Actually, 80 to 90% of people with MS will present with relapsing remitting at first. Essentially what happens is you have episodes of rapid, abrupt, and unpredictable deterioration with variable degrees of recovery over time and minimal residual disability. So if you look at that first chart here on the top right, you can essentially see increasing disability over time. And what you can see with relapsing remitting, for a majority of people, they will have a baseline performance of functional activity. They will have a burst of increased disability or lack of functional abilities, and then they will drop back down to baseline. Now, unfortunately, for many people, they will have that type of recovery where they have an exacerbation and then they return to a complete recovery. But there are a number of people that will not make a full recovery between exacerbations. And this is the progressive form of MS. So this is relapsing remitting, both types are, but relapsing remitting can present itself with no loss of function between exacerbations, I should say little to no, or it can present itself with significant loss between exacerbations. Now, there's many research studies out there that suggest that this might not be a disease state. This might actually be the type of treatment, the steroids that are given, as well as the rehab in between exacerbations. So this is something we may be able to modify. Now, primary progressive, we can see our chart on the right here. It's characterized by a steady progression of continuous worsening with some minor fluctuations, but without distinct periods of relapses and remissions. So primary progressive is only about 10% of people with MS, and it does affect males more than females. And ultimately, you don't have those major exacerbations, but unfortunately you do have a progressive loss of function over time. Secondary progressive, so we start off with relapsing remitting. That's the most common. 80 to 90% of people with MS have relapsing remitting. Of those 80 to 90% with relapsing remitting, 80% of those individuals will then transition into something called secondary progressive. And the chart on the right here tells the story perfectly. You'll start off relapsing remitting, whether you're having any deficits that will stick around or not. It's relapsing remitting nonetheless. And then over time, you stop having exacerbations and you switch into the progressive mode. So this is highly common. Now, one challenge that we're faced now with today's medications is the medications that are used to treat multiple sclerosis are actually extraordinarily effective at preventing exacerbations. So it's often hard to tell if a person is still in the the relapsing remitting stage when they're on these medications. They'll have reduced amount of exacerbations and as a result will appear to no longer have exacerbations. However, they might appear to have some progressive loss of function. So there is a question as to whether or not somebody's in secondary progressive or if they're in relapsing remitting with an effective medication. The good news is the medical procedures and diagnostics are so strong now that we can do spinal taps and measure the amount of oligoclonal bands, which is what remains after you have a breakdown of oligodendrocytes. Measuring that can tell if a person is in an active state of MS, and that can help the MDs determine if they're in a relapsing remitting, primary progressive, or secondary progressive mode. Now we also have progressive relapsing. So this is far less common, but it is a possibility nonetheless. It's a steady progressive deterioration from the onset with clear acute relapses that may or may not resolve. Now, in a majority of cases, the best way to describe this is relapsing remitting with little to no resolution or improvement between each exacerbation. This is a difficult form of MS and does not have an excellent prognosis. So this is a nice little summary from Medscape. There are a number of these out there. I caution you to refer back to the iBook here for your information, or you can refer to the textbook as well. But be careful because there's a lot of images on the websites and online that are actually inaccurate when describing the different types of multiple sclerosis. All right, so conversational knowledge. There are multiple different types of scales that are important to know with neurological rehab. One of them is the EDSS, Expanded Disability Status Scale. It's a scale of 0 to 10, specifically detailing a person's functional capabilities, and it's used exclusively in multiple sclerosis. It's imperative that you know this. There'll be many cases on tests and on boards where you have a person described as having MS, and the only information you get is their EDSS score. So based on that, you need to be able to deduce their functional level. Okay. And this is just a visual representation of the EDSS scale. So make sure you review that and know the details of it, and this is something that can be covered in class with Dwayne Grell as well. So EDSS is the most common. There are others. There are many others related to MS, but the ones that are commonly used in research, clinic, and might be seen on the boards are your EDSS, your MFIS, the Modified Fatigue Impact Scale, and the MS Quality of Life Inventory. So it's important to note all three of those, understand what they are. With regard to medical diagnosis for multiple sclerosis, we have originally we got a discussion about how difficult it was to diagnose MS. So going back to the 80s and 90s, there was no definitive diagnosis and there was no clear-cut test. So it was actually a rule-out diagnosis where there was no definitive way to know it was MS. And as a result, there were a number of people that were misdiagnosed. And as a result of that, there were a number of treatments that came about that were not appropriate for MS and were actually treating whatever the real ailment was. So the great news here is we now have definitive diagnostics for MS, and as a result, people are getting diagnosed much earlier and ultimately having better prognosis because of the early diagnosis. Probably the easiest and most descriptive diagnostic is the cerebrospinal fluid assessment. So a spinal tap, which goes for gamma globulin and white blood cells, but it also looks for the oligoclonal bands, for the breakdown of the oligodendrocytes. Okay, so to have a definitive diagnosis, though, we still have some loose criteria. So you have to have documentation of 2 separate neurological lesions in the central nervous system that are temporarily and spatially distinct. So temporarily meaning time-wise, so they have to be greater than 30 days apart, and spatially distinct, they have to be anatomically separate. In primary progressive MS, you have to have a slow progression of signs and symptoms over at least 6 months is required for your diagnosis. Now this is confirmed with MRI, evoked potentials, and cerebrospinal fluid assessment. Medical management is extremely important in MS. This is an area where you definitely need to review this and make sure you have a strong understanding of the medical management, most particularly the pharmacological agents. This is something that's extremely important that will come up on the boards and testing in this course. So medical management of the symptoms. These pharmacological agents are usually used for the symptoms, not necessarily for the disease itself, although there are some for the disease. So let's take a look at that. Spasticity. Spasticity, if you haven't talked about in other classes, you want to take some time and ensure that you have full knowledge of this slide right here. You want to understand what baclofen is, both names for it, baclofen or Lioracel, and also the other options like tizanidine, dantrolene, and Valium. Okay, so muscle relaxants is essentially the class here. The problem with these is they don't just relax the muscles that you need relaxed. They don't just relax spastic muscles. There's an overall relaxant effect of them. So you have sedation, weakness, and fatigue, And essentially, this is exactly what a person with MS does not need any more of. So overall, a therapist has to be a very big piece of the puzzle. A physical therapist has to be a big part of this puzzle here. Often a neurologist will ask that the physical therapist monitor the patient's performance, perform some outcome measures, assess how they're responding to the medication at their highest dose versus their lowest dose. When it comes to baclofen, for example, it generally has a 4 to 6 hour half-life. So you'll note that a person will take it. After about 1 to 2 hours, it'll start to have its maximum effects, and that'll last another 2 to 4 hours. So you can almost predict the timeline with the patient and utilize that to determine their exact levels of medications that's going to impact their spasticity at the appropriate levels without over-fatiguing them. Naturally, we're PTs, so we're not going to be changing the medications, but we will be consulting the MD, working with them on this, and they will be asking for our assistance as well. There are some other options here. So we have heavier duty medication like Tegretol. This is for the really sudden, sharp onset spasms. Then there's intrathecal baclofen. So if a person has taken oral baclofen and they've exceeded the maximum dose that can be taken orally, they may need to switch to intrathecal baclofen. For this, it's actually a pump that is inserted surgically into their abdomen with a tube that goes directly into their cerebrospinal fluid and directly gives them the baclofen to their nervous system. Some other options are botulism or Botox, phenol injections, and then ultimately surgical intervention. And again, you want to make sure you're fully aware of these. When it comes to pain medications, we want to be extremely aware of what pain medications our patients are on. And the reason being, multiple sclerosis, as in all neurological conditions, is a central nervous system issue. And any pain medication that is treating the pain in a central manner is ultimately going to reduce central nervous system function. As a result, it could actually limit our impact of rehabilitation on a patient. For neuroplasticity, we want to have a high level of neuroplastic return. We want to have a high level of central nervous activity. If we're on pain medications that are limiting that, as a therapist, we're going to have to balance between the timing of the patient's pain medications, patient's tolerance to pain, and our home exercise and or therapeutic exercise program. Fatigue, a major symptom, major issue for MS. Some of the more progressive MS centers are now prescribing anti-fatigue medications. Now, these are not specific to MS at all, but these are specific to fatigue. So amantadine is a neurological stimulator that is often used, but so is modafinil and 4-AP. So modafinil is Provigil, which is essentially provides increased energy as well as mental focus. 4-AP is a different type of medication where 4-AP, 4-aminopyridine, it actually increases the conductivity of the nerves. So this impacts fatigue by increasing nerve activity. This is also dubbed as the walking drug, and this 4-AP is a short-acting medication. So you take it, a person often describes feeling jittery as if they had a strong cup of coffee, and then having better functional performance for about 2 to 4 hours. Now, there's been a big surge of utilizing the extended release version of this, which is called Ampera. It's not listed on the chart here, but it's Ampera is the extended release long-acting version of 4-AP. For tremor management, these medications are all directed towards tremor, not towards MS. It's important that you know the list of medications of what will impact somebody with tremor. Cognitive and emotional impairments, same answer here. These are specific to cognitive and emotional impairments, not specific to MS, but it is important that you're aware of these possible medications as these are the most commonly used meds for MS. Bowel and bladder, again, same answer. These are the common bowel and bladder medications. So make sure you read through this and have a full understanding of all the different types of bladder issues as well as the medications that will impact that. Now, signs and symptoms. This is an area where we could literally talk all day. But again, we now know that MS is a brain or spinal cord injury, which results in damage to a lesion into an area, which is essentially a focal lesion. Now, this focal lesion is going to present the same way it would in brain injury or stroke. So it's important to understand that with MS, while there are some standard symptoms, which we're going to talk about now, anything within the central nervous system is fair game. So on eval, you need to evaluate your patient, do a full comprehensive neurological eval to ensure that you've addressed all of the needs of that patient. Now, the most common symptoms by far are gait and fatigue. Fatigue being 88% of people with MS have fatigue, and gait disturbance, 87% of people have gait disturbance. Not far behind there is bowel and bladder issues at 65%, pain at 60%, vision at 58%, cognitive deficits 44%, and tremors at 41%. So this list here is a list of the most common symptoms broken down by motor, sensory, visual, bowel and bladder, sexual, and cognitive and emotional symptoms. Really, it's super important that you understand the list of them, and it's important that you understand that MS can affect anything through the central nervous system. Now, one of the areas that is not dependent on a focal lesion is fatigue. So this is the most common single complaint in MS, almost 80%. Actually, we know it's more than 80%. So this fatigue is not your typical fatigue. It's not how you would feel if you're just tired because you haven't slept. It's divided into primary and secondary fatigue, and primary fatigue is also known as lassitude. This type of fatigue is weariness, lethargy, stupor, exhaustion, sluggishness, and tiredness. Again, it's not just how you would feel if you didn't get a good night's sleep. It's more the way you might feel if you had just run a marathon and didn't have good sleep and then sat in a sauna. So if you combine all the different aspects that will deplete your energy source and make you feel lethargic, this is how patients will often describe primary fatigue. Now, for all different patients, they have different reactions. Some patients will say that they're fatigued more in the morning, but it is more prevalent that patients will be more fatigued in the afternoon and evening. Worsening of fatigue with exercise and heat is very common. It does not correlate with the degree of impairment or the functional limitations. When it comes to this fatigue, it's important that you understand it and you work around it. You try not to work with a patient when they're overly fatigued, and you try to work with them when they're not as fatigued. Now, exercise is a topic that has changed significantly, and it's imperative that you understand that a person with MS can exercise. Historically, back in the 80s, the medical doctors and physical therapists would prescribe rest for somebody with MS because they didn't want to over-fatigue them. That ultimately caused secondary impairments that come with rest and legitimately started to progress the MS faster. So what we now know is people can exercise. The key is preventing and increasing core temperature. I did a study on MS where I had people fatigue their triceps and bicep muscles to full fatigue using a professional training regimen. Those individuals had no increased incidence of exacerbations and no increased incidence of fatigue after their exercise. In fact, they reported increased energy after exercise. Now, that said, I monitored and ensured that their core temperature did not increase. Had their core temperature increased, they could have presented with something similar to an exacerbation, which is called a pseudo-exacerbation. And this happens when somebody gets overheated to the point where they can't function, and it looks like an exacerbation. But as soon as they get cooled down with air conditioning or ice packs, they get right back to normal. So then there's secondary fatigue, and this is the normal type of fatigue. This is what we feel when we're a bit out of shape or deconditioned, when we've pushed our bodies too far, or any of the areas of this list here. Fatigue and exercise, again, I can sum this up by saying that you should work around the fatigue, but do not shy away from exercise with a person with MS. Ensure that they're not elevating their core body temperature too much and not putting themselves in harm in that respect, but they should absolutely be exercising. Sensory changes are extremely common in MS. 65% of patients will have some sensory issues. There is something that is called the MS hug or the MS girdle, and essentially it's a common dysesthesia around the core or around the trunk, where a person has abnormal sensations, including burning, itching, electric shock, wetness, or even a tight banding around their waist. So that's something to be aware of. Also, we could talk about Leheret sign here, and this is a shock-like sensation in the spine or lower extremities produced by rapid neck flexion, as in coughing, and it's indicative of a dorsal column demyelination and damage. The way I think of this is if you had demyelination of the dorsal column and you had scarring, when you flex your head, you're pulling the dura and you're stretching it and you would feel a shock of pain. Okay, so this is not limited only to MS. It could be caused by other conditions. Trigeminal neuralgia, you've already learned about this, but if not, make sure you go through and read this and understand it. It is found in patients with MS, but a small number, about 3%. However, when it is coupled with MS, it tends to be a worse form of trigeminal neuralgia and is a very painful, very significant deficit for that individual. Okay, weakness, we've discussed, and visual disturbance makes sense based on region of the brain. Spasticity is due to the upper motor neuron involvement. And then lastly, the last thing I want to talk about is heat sensitivity. So this is not peripheral heat. This is not just easily measured with a thermometer. This is core temperature. If a person's outside too long in the heat, if they take a warm shower, a warm bath, if they get overheated from exercise to the point where their core temperature were to rise, this is ultimately going to cause them to have pseudo-exacerbation. They're going to be more fatigued. They're going to be less capable of performing functional activities. Okay. Ataxia is going to be much more of a symptom-dependent, focal lesion-dependent issue, along with tremors and the pain as well. And this rest of this area just kind of goes through the different types of secondary symptoms, which I'm not going to read through. I trust that you can read through them, and this will also be covered with Dwayne Grail during the lecture, during the lab portion of the course. If you have any questions with MS, please don't hesitate to contact me. Thank you.